All right.
Everyone. Good afternoon. Welcome to Embedding a Health Equity Lens into Health Improvement Planning as part of our Health Equity series. I'm Courtney Jeffers. I'm a co-lead of the Maine Public Health Association Health Equity member section. We're really grateful that you're joining us today. Thank you. Before we get started, just a couple of housekeeping items. So live transcription is enabled if that feature is helpful for you. Also, this webinar is being recorded, so if you don't feel comfortable being on a recorded webinar, please go ahead and leave the session now, because we will send out the recording to all the folks who register and post it on our YouTube page within the week, so you can watch it at a later time if you don't want to be recorded. Also, folks might be trickling in and out, so we might expect a few more people. We'll take questions at the end. You can use the chat to ask your questions as we are listening and learning from Liz and Zoe, or you can ask them at the end and I will facilitate a Q&A. If you have any technical issues or technical questions, please use the chat feature. We have Becca here for our technical backup. So that's it. With that, I will turn it over to our two presenters today, Liz Blackwell-Moore and Zoe Miller.
Great, thanks so much. Hello, everybody. Nice to see you all. A slight warning shot. We're hoping that you all will do some participation along the way, because we think that this work is work that is very it's always a learning process, and we're always in learning mode on this. And so our hope was that you all would participate with us in this. So of course we have some things we'll present to you, but we'd love for you to be sharing your own experiences and the things that you're thinking about along the way. So I'm Liz Blackwell-Moore, and I am the Cumberland County Public Health Department Director. It's like a newer position here, about a year into it. And Zoe, do you want to introduce yourself, or should we just keep going and then we'll get to the introductions? Okay. Okay. All right. So I'm just gonna. So what we're here to talk about. So today we are going to share with you how we define using health equity lens. And we are going to do that also through telling you the story of how we used a health equity lens in creating the Cumberland County Health Improvement Plan, or Community Health Improvement Plan. The C can be many things, I guess, in CHIP. And we would like to share with you our insights and lessons learned from that process and from that project. And we'd love to have, we're going to offer some time for discussions and questions along the way, and of course at the end as well. So we thought it would be important to share with you kind of who we are and how we came to focus on health equity. So I think that I can see when it started for me. I think part of a big shift for me was when I went to college, my first class, I thought I wanted to be a doctor, but my first class that I took was called Race and Ethnicity in the United States, and it was a sociology class. And it really blew my mind in terms of the ways in which systemic oppression had been sort of built into the framework and the systems within the United States, but also how they carried on into current day. And I think that really set me up for thinking about, I'll also say I got a C in chemistry. So that really sort of nailed it that I wasn't going to be a doctor. But I think also, so then when I was a case manager for folks who had HIV and substance use disorders and also had mental illness, and mostly came to our program homeless, I think that set me up for seeing the ways in which they had been impacted so incredibly negatively by every system they had encountered. And so I think I was sort of the light was shining on all the ways in which systems create inequities for people who are, for specific people living within communities. And so that sort of carried on through my career in public health. And I think I worked at the Opportunity Alliance for many years and was a public health consultant, and now doing this. And I think that I, throughout that time, sort of am oscillating between how do we do universal strategies, really impacting you know, the big picture, everyone. And then how do we really also do that focus work and making sure that those who have the greatest barriers to health, that we're actually really focusing on them. And Cumberland County is such a really great example of, you know, we just got, you know, it's just like Cumberland County was in the top 25 healthiest counties in the nation. But when I look around and we see, like, there are so many people that I would not put into that category of like feeling like they're the healthiest folks in the country. And I think that's really that it's like that it became very clear to us that we had to focus on those with the greatest barriers to health. So that's sort of like the lens and the way what I bring to this project. So Zoe, I'll let you introduce yourself.
Great, thank you, Liz. Happy to be here. Thank you for asking us to come and talk about this. So I think I actually chose this image here of an intersection because I really think, Liz and I both come at doing health equity work from a number of intersections of topics. And so for me, I think I was thinking about transportation and transportation access from a pretty young age, and paying attention to the environment around us that we built and how it does and doesn't work for people. And I grew up in a working class town in southern Maine and learned about our country's decision to do what was called urban renewal, that left my town in particular with a bunch of dirt parking lots in the middle of what had previously been a thriving Main Street. And so as I, went to college and got out of college and got into doing neighborhood-based work, which turns out was public health at the time. I didn't really know to define it that way, but I was working in communities that were part of the housing authority in Portland and had been built by, again, probably, similar kind of out of the nation's policies about how to provide housing. And these weren't always the most pleasantly designed neighborhoods. And I was working with families and getting close with kids and families who were experiencing the downstream effects of policy decisions, and really found more and more that I wanted to get involved with upstream solutions. And so that led me to do, I sort of think of was like a widening circle of going from working with kids to working with kids and families to working with whole communities and eventually regions. And I went back to school after working in the field for about 15 years to get my master's in public health, and was like, oh, it's all public health. That's kind of the perfect lens for this. And really looking at how I could be continuing to stay connected to people who were having these lived experiences of whether it was not having great transportation access or not having safe places to cross the street to get their kids to school, that I could take those voices into policy level work. And that led me to work in transportation and land use planning for about 5 years. I was with the Greater Portland Council of Governments. And last year I decided to go out on my own as a consultant, but I'm continuing to do a lot of that same kind of work and really looking at how do we create more inclusive decision making, because so many of the issues that we see and the inequities are related to not having people be involved in the we of making our community what it is. So I got to join up with Liz to work on the Cumberland County Community Health Improvement Plan. So I'm excited for us to get to tell you more about that today. I'll hand it back to Liz.
Great. So we actually would love to know a little bit about who you are. And I know that some of you don't have your camera on, which is fine, but if you would like to use your little hand controls by raising your hand in the, what is it? Function. I can't see them.
Is it in the reaction?
Reactions.
In the reactions. Okay, great. So if you could raise your hand. Raise your hand if you have worked on a health improvement plan in the past. And you can physically raise your hand, or you can raise your hand on the little button. Okay, great. How about raise your hand if you're working on a community health improvement plan right now? You're working on one? Oh, you are, Skylar. Okay, great. How about raise your hand if you feel like you have a strong vision for what health equity is? Okay, great. I see some more hands. How about raise your hand if you feel like you're implementing strategies to address health inequities? Okay, so a few folks. Great. And how about raise your hand if you have embedded health equity into your health improvement planning? Okay, great. All right, well, I'll promise I'll try not to put you on the spot, Skylar, but you know, I might. So it sounds like we have sort of various folks in various stages of health improvement planning and also sort of embedding that health equity. So our hope is that today we can all kind of learn from each other and figure out. I mean, I think this is like this will be the work for me anyway. This will always be the work. So it's like a constant learning process. So it's great to have you all here with us, to be in it together, learning from each other. So in terms of like what health equity is, you know, from the US CDC, they have, you know, health equity is achieved when every person has the opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So I read this and I'm like, okay, first of all, it says his or her. There's a lot of jargon in here. Like I feel like it's even just the words health equity, I feel like we know that people hear that really differently and don't have a lot of definitions for what does equity mean. So I'm wondering if folks would be willing to talk about, how do you talk about health equity without, you can use the words or not, but I would love for you to share what's the way you talk about it out in community or when you're working with folks, because I feel like this is a lot of jargon. Anybody willing to sort of step out there and share with us?
I know for me, I usually start framing it with non-medical health-related social needs. That's typically where I start in my work with how those particular social risks and social needs kind of draw us into health disparities, and then how that impacts health inequity. It's to get people a little more where they are if they can see something that's in their community. It does me at least.
Yeah, great. Thank you. Anybody else have anything they'd like to share of how you talk about it or how you?
I can share that. I think a lot of recent definitions or different plans, organizations have started using like fairness and justice as terms to talk about equity, and everyone having like fair, basically like achieving fairness and having like opportunity to access different things. And I think that those, I don't know, I like that framing of it personally, because I think it's more relatable and it's kind of like I guess almost like universal values, even though we think about those concepts in different ways. It's a bit more palatable than using like big words and phrases.
Yeah, that's great. Yes, I know. Yeah, the fairness and justice, like when we've seen all the pictures of what is health equity and sort of moving towards justice, and fairness definitely is one that helps people understand, seems to really resonate with lots of people. And I feel like even in our time doing the county health improvement plan, we've shifted our language quite a bit on how we talk about it, because we had to go out into the world talking about it so much that there's been a shift over time. And so, and I talk a lot about, I think I've ended up using like that there are people and groups of people who have the greater barriers to health. Like I've been trying to keep it super simple, and then, for myself, because I feel like, but again, in 3 months, maybe talk to me and I'll be talking about it in a different way. I think it's like evolving, but trying to find those things that really resonate. And I know that Frameworks has done some work recently on fairness and justice being some of the words that resonate more with folks. Great. So Zoe, go ahead. You are muted.
Oh, okay. Great. Thank you, Liz. So we wanted to talk about how we currently, at least as we said, it's evolving, but how we're defining using a health equity lens. And it was really interesting to do this after we had completed the Cumberland County plan, because I think we even realized some things that we were, it was like putting words to some of the ways that we had handled things. So I think I feel like it's just constantly a learning process, and that will bring into future projects. So, I think first and foremost, it's really intentionally looking for how to address social, structural, and political forces that are shaping our health and well-being. So, we're all getting used to hearing the language of social determinants of health. And then, I think it's been more recent that we're hearing the term structural determinants and political determinants of health. And I think these are all, again, these are sort of big words, like a more complicated way of saying it's about, where you are in the system and what supports you have, what pressures you have on your life. And I think those are pieces that are not visible to everybody, or they may have disagreements about them. And so I think it's like tuning in to seeing that and applying it to the work. Next slide. And kind of building on that, it's, really about paying attention to the impacts of these issues that are based on people's identities. So tuning into the impact of discrimination and stereotyping and prejudice, and seeing how those are precursors to then having different health outcomes and experiencing different community conditions. And I think, in the world, actually in transportation planning, I've found that, this paradigm comes up too, about considering the positive and negative effects. Seeing the positive and negative impacts of policies and programs on underrepresented or underserved groups. So I think it's interesting to see how this is a piece that's been called for in civil rights laws for many decades now, but I think is still really challenging for people to build in. And I think one of the most powerful ways that we see to build it in is to be hearing directly from people who are either working closely with underrepresented communities or are themselves from an underrepresented community. Can go ahead to the next one. And this is related, that it's also about balancing community expertise and knowledge with what we get from research. And so, we hear a lot in public health work about using evidence-based practices, and there's strength to that, in that I think, shifting even just in recent, say over the last like 20 years to saying, well, we want to make sure what we're doing actually works. We don't want to just do something that we think is a good thing. But at the same time, balancing the fact that there will be community approaches and knowledge that hasn't shown up in the knowledge, the research base. And that, communities that have less resources probably aren't, going out and researching and writing white papers and getting published. So we don't want to create an undue, create an imbalance there. And then, I think the data is important, obviously. And so prioritizing using disaggregated data. So, going back to what Liz said at the beginning, you can look at Cumberland County and think, wow, we're doing great. Looks like we're good. Let's just keep doing what we're doing. But when you start to break it down by income or by disability or by race and ethnicity, you start to see a different story. And so I think what we saw very clearly when we were working on the Cumberland County plan is that we aren't necessarily collecting enough data, like our sample sizes aren't large enough to be able to disaggregate down to the level that we want to. And so I think there's work to be done there. And in the meantime, acknowledging, using the sources that we can and acknowledging when it's missing, and acknowledging those limitations, I think, is also part of how we can be addressing the challenges there.
So we thought you'd share with you about our process for our county health improvement plan, and then some of the outcomes of it. And so I did the lead on this because we used American Rescue Plan Act funds to help with this, Chip. And we had an advisory committee that was mostly made up of folks who are paid staff of public health organizations within Cumberland County, and then also some folks who do some statewide work, but have a particular connection to Cumberland County, like Becca. And so our goals for the CHIP were to create a county health improvement plan that could act as a guiding document for public health generally, all the public health organizations in Cumberland County. And then a secondary goal was really to help identify some of the foundational public health programs and capabilities that could belong within the new Cumberland County Public Health Department. A big thing for me developing a department here is that I did not want to do overlapping or competing work, but really figuring out where are the gaps and what should be the work that we do here versus all the other folks who've been doing public health in the region for a long time. So our vision for the county health improvement plan was that we envision a county where communities are thriving, residents, organizations, and local governments connect and invest in collaborative actions, and every person has an equitable opportunity to live a healthy life. And so I think we wanted to build into the vision this piece around equity because we already knew, having looked at the preliminary data, that was really the biggest issue for us in Cumberland County is this huge divide between some folks and other folks. So we were looking for frameworks for thinking about how do we do this work. And this is from Boston Public Health Commission on the way they think about health equity, and that all of these all of the ways in which people are oppressed have huge impacts on their health outcomes through all the community conditions in which they live. And so I think that was sort of what was in our minds when we were starting this process. And so we were trying to develop a frames that we could help explain that to the folks that we encountered and that we wanted to talk to along the way. And so we started with kind of how do we define health? And the city of Portland was working on their county health improvement plan, and they had already created these domains of health, of healthy minds and bodies, healthy households and families, and healthy communities. And so we asked if we could borrow those because we felt like it's such a great frame of domains of health, and then also for continuity, right, between our organizations, since we have overlapping communities. So we then said, well, what influences our health? And so we wanted to explain to folks that it's not just health behaviors or access to care that influences health, but that it's also social and economic factors and institutions and systems. And so then we asked this question of, how healthy are we? And that leads us to looking at not just health outcomes, but really looking at community conditions. And so we used this, we showed folks this frame at kind of every step of the way, from advisory committee members to anyone that we asked a key informant interview of, or that we talked to through the coalition, focus group work that we did, kind of explain this model for how we were looking at health. So that led us to thinking about, so when we looked at the data, we could see in the data really clearly that there was huge differences, right, between, people who identify as BIPOC or LGBTQ+ or live in rural areas versus, folks who are white and higher income and higher education. So, and in, greater Portland. So we we were looking for frames for how to address health inequities, and we found or we had seen this before, which is called the BAR, we call it the BARHE, the Bay Area Regional Health Inequities Initiative. I think it's from about 2009, and now is part of California's work on health inequities across the whole state, actually. And so we borrowed from this and used this as a way to explain the work that we were doing. And so our version of this public health framework for reducing health inequities is to start with sharing with folks that this is sort of like the common way in which people think about disease and death, that we commonly think about like that risk behaviors impact people's risks for disease and early death. And that public health, primarily in the common public health practice, has really involved like, okay, we do health education, right, to help people reduce their risks, or we, make sure people have healthcare and treatment, or we do policies that are really specific about risk behaviors. But that if we really want to think about how do we address health inequities, that we want to start moving upstreams, because we know the research shows us that community conditions that people live in have huge impacts on their risk behaviors. And that those community conditions are really impacted by social and institutional inequities. And so the work of public health and moving upstream and moving into that emerging public health practice is figuring out how do we build partnerships and capacity and policies that are really impacting those community conditions and social and institutional inequities. And so the CHIP, we really were trying to work on how do we find strategies and do work that's impacting those conditions, community conditions and inequities. So when we talked about with folks, so we had, a lot of community engagement. I think it's easy for folks to see kind of where does public health fit when we're talking about like reducing, risk behaviors. I think it's harder for people to see like, what is the role of public health when you're going upstream? And so we actually would share before we ask people questions about, what they thought were the issues and what they thought we should do. We shared with them that, public health is really, we are just like a doctor diagnoses the health of individuals, public health diagnoses the health of communities. And that we can work to support and facilitate community engagement and look at the data, that we cooperate with many organizations and communities and facilitate that connection and partnership, and that we prevent health problems before they start. And so this, I'm not sure how many of you have seen this sort of framing of public health through the phrases work. Have any of you seen that phrases work before? So phrases, and I will put it in the chat when Zoe starts talking, but the phrases it was a combination of the de Beaumont Foundation with frameworks and a bunch of folks saying, how do we help people understand public health a little bit better? And they did a bunch of research on what are the key things that people need to hear to be able to really take in what public health does. And they came up with these 3 key words: diagnose the health of communities, cooperate, and prevent. So we use that, and I feel like it really worked really well. I feel like people really got what we did and came up with strategies and suggestions that were based on really on this and understanding what it is that public health does, which has not always been my experience when talking to folks in the past as a public health professional. So we then use like a sort of a series of prioritizing questions. And I think, for us, we really had this it was like that health equity lens was on when we were thinking about the questions for how do we get to understanding the problems and then building in the strategies to the chip that are going to have the biggest impact on folks who have the greatest barriers. I just paused for a second because I thought I lost Zoe for a minute. I didn't see you, Zoe. Sorry. I was like, did she leave? So there you are. I somehow thought you got like kicked off the thing. Sorry. So, some of our big questions were like, what communities do you see are most impacted by this problem? And I'll even say like our language changed as we went and as we talked to people. How is the problem being addressed now? What is it a root cause of other problems? We were really interested in getting at root causes because we know that's how you can address health equities, is getting at root causes. What strategies to address the problem best fit with the culture of your community? So these were some of the questions that we were asking of folks and also of ourselves as we were doing the work. So our process for engagement, we collected a lot of data on health outcomes and community conditions. That was, of course, as Zoe said, we tried as hard as we could to find that disaggregated data and acknowledging when we couldn't find it. We gathered a lot of information about what people were already doing, what they thought were the gaps, and when we really mostly were asking people like, what strategies do you think? Because really, people know. They really do. They know what they have really good sense of what would be best for solving a lot of these problems. And so we talked to people who were working within specific health topics. So, for instance, like food security, we went to the Cumberland County Food Security Council, but we also talked to folks who were working to specifically work with affinity groups, whether that's like the trans health, the main transnet, or folks who are doing work specifically with LGBTQ plus folks, or older adults, or rural folks. We were really trying to ask the questions specific to those specific groups. We also had 2 town manager meetings, and we had a superintendent's meeting, and we did some surveys as well. And then we researched what the strategies folks gave us as their suggestions, and looked at what do we see as the public health evidence around those suggested strategies. And then the advisory committee worked to prioritize the strategies that were really most likely to have an impact on health equity, on health inequities. So I'll say, so we interviewed 40 key informants and key leaders. And we don't have the chip for you. I wish I could say, here's the link to the chip. It will be done really shortly, but you'll have that. So it's kind of tiny, so you'll be able to read it when you get the full chip. And then we engaged about an additional 200 people through coalitions or meetings that we had specifically for the County Health Improvement Plan. We did kind of like meeting takeovers, essentially. So we would go and to, like the Food Security Council or the Lake Region Community Action Network meeting and presented on the chip, and then had a series of discussions around what people thought were some of the gaps and solutions. When we got to our list of strategies after we'd done like a bunch of the research, I think this part might be interesting to many of you who are thinking about how to include health inequities or health equity lens into your chip work, because we leaned into prioritizing strategies that really were going to have the most impact on health inequities. So the magnitude, so we had like a scoring that gave us a little bit different scoring than I've seen us have in the past, where because we scored more heavily for things that were going to have an equitable benefit, that were really fitting what people said needs to happen, and that we thought were going to have the biggest impact on the needs and gaps that people identified. Because I think often when we've done our sort of CHIP work in the past, we've really done what's the problem that has the biggest problem that people keep saying, oh, this is the biggest problem. And what that means is you keep getting the same 4 things sort of rise to the top over and over again, or the same thing, one thing, it's like behavioral health keeps rising to the top. And so you keep doing things that are really actually, it just, in this case, that has meant that we've done a lot of downstream work, as opposed to like, how do we move ourselves towards going further upstream? And I think tipping the balance towards those things that are going to address health inequities helped us get to kind of a broader range and more things that were upstream. So in terms of what we ended up with, in terms of our priority issues and strategies, we had a priority area of advancing health equity. It's really built in throughout, but we had some specific strategies we wanted to call out around health equity. We had some, behavioral health and oral health care under ensuring healthy minds and bodies. And then the majority of the strategies really fell under building health communities. So, in terms of expanding the use of cross-cutting equity strategies, we really, we have a set of 3 strategies that are really process strategies around how we do the work. So, using that equity lens and culturally relevant approaches, but then also doing work, we wanted to build out strategies for building cross-sector collaboration and partnerships to specifically address health barriers for folks who are LGBTQ+, immigrants, refugees, and or seeking asylum, and folks in rural areas. In terms of behavioral health, we in each of these, I feel like it'll bore you if I go through all of these, but I think that what we were working on here is really trying to figure out where are there those differences in outcomes, and how do we build strategies that are going to address those differences in outcomes. So you see here we have a lot of things that are well known to support improving behavioral health, like behavioral health liaisons, but also like more of coordinated systems for harm reduction and overdose prevention, and then some work within schools. In oral health, we, a key thing was figuring out how we could provide an infrastructure for building out a more robust delivery system for children's preventative oral health, but also this piece around supporting efforts to improve culturally responsive oral health care for children and adults. And really kind of jumping on to some efforts that were already underway with this, the equity, Zoe, what's the name of the group? The Oral Health Equity Coalition. And then building healthy communities, when we start talking about improving transportation, some of the things we thought that public health could be really good at working on is funding looking at how to fund free fair transit and mobility management. For addressing racism and discrimination specifically, we thought, working on building capacity within schools, participatory grant making, and really being that connector between organizations and municipalities who are trying to work on addressing their racism that's built into their systems. When it came to housing, safety, and security, there's some advocacy work that public health can be doing, but also on building capacity for eviction prevention work, and also really around household toxins and supporting renters to get their needs met around that. And food security, is really jumping on board with the Cumberland County Food Security Council, but also making sure that everybody who qualifies for benefits can get those benefits. And then environmental justice issues, you know, there are organizations that are doing environmental justice work across Cumberland County, but it's pretty separate. And there also are, it's a little bit more siloed, and we felt like this is a place that really could use some more public health effort for supporting it, because race and socioeconomic status are the most significant predictors of whether a person lives near contaminated air, water, and soil. So in terms of like our next steps, you know, we're implementing the strategies collaboratively as a whole group, and our work is to really help build capacity across Cumberland County. It's not to take all of this on ourselves as like, oh, now the public health department's going to do this, or now City of Portland's going to do this. It's really around like, how do we build the capacity of all these folks we just talked to and all these communities to be able to do this work and address these issues. And I think that's another piece around the using a health equity lens, is like, we don't solve the problems right by ourselves, we solve them together. No.
So with what we wanted to do before we go to questions and discussion is kind of share our reflections on all this. So, you know, anytime we're making a change in practice, obviously it's, you know, there's some components that are necessary to get to make that practice change. And so if you want to go ahead and advance the first one. So I think, you know, one of the sort of top pieces we see is the need to lean into that it's a relational process, and that valuing relationship building as one of the plan's outcomes is really key. I think, and this is, you know, I think the great thing is that so many folks who are working in public health see things this way. But I think often our systems are not functioning that way. So realizing that there'll be work you can't do until you build the relationships. And so building the relationships is part of the investment that you need to make through the process. Next one. And you know, it's messy. And so being willing to wade in, I didn't even click the little the metaphor here with wading into the upstream, but that we're, you know, it's not totally clear how public health relates with upstream issues. You know, I remember a point where we were saying, do we get involved with housing? Is that public health's role? Does that make sense? And what I think we saw there is how public health can bring some of its coordinating capacity to housing challenges. It can bring some of the health equity, centering health equity in housing decisions to the table. So it's a matter of figuring out what that role is. And choosing strategies without knowing where funding will come from. I mean, I think this is really a big one that I think historically we've seen a lot of community health improvement plans and planning in general. I mean, I've seen this in the transportation world that's done in a fiscally constrained way. And so I think what we really we had to at some point take the leap and say, we don't know how all these things will be funded. And this isn't actually a work plan. What this is an aspirational plan around the health issues that we're seeing and the approaches that are most suited to addressing them. And taking somewhat of if we build out this plan and we identify these needs, then you know, then the opportunities will come. We'll attract the resources. We're certainly not going to attract them if we don't prioritize these things. And then you know, I think overall is embracing that public health improvement planning can be iterative. So again, I think it can be easy to say like, oh, we weren't going to do, you know, this wasn't in our scope of what we were going to do, or we expected to get all the way to, you know, point see, and then realizing that we needed to make some adjustments. And we saw that in the, you know, specifically the way that connected to not quite having the relationships in some places with some of the communities. And also that in the midst of COVID and all of the related challenges that communities are experiencing, that it wasn't necessarily, we couldn't get everybody we wanted to the table in the time frame. And so we made adjustments to how we handled that.
Oops, sorry.
So a little bit about what it looks like in practice. And I think, Liz touched on this a bunch, but it's, shifting language to be more specific and direct. And so I think we, let's say what we're talking about. And so, yeah, we are talking about inequities, and we are talking about justice. And we also need to think about how it will resonate with audiences. So, we did adjust our language and use slightly different language with different audiences, being mindful of how different ways of talking would fall on different people's ears. And so I think, the phrases, the tool that Liz mentioned earlier is really helpful and has a whole section on, interfacing with different sectors. So just helping you think about how your public health message will land with folks who are working in housing or government or what have you. We also thought a lot about framing to avoid harm and to place responsibility on systems and not individuals. And so thinking about the sequencing of when we're talking about health outcomes, where we're leading with the information about the issues that are different, the community conditions that are different, so that we're not presenting as somehow it's people's fault that they have that their health outcomes look the way they do.
And I'll say with that one too, I think for we didn't show it to you, but we in the final document we have a lot of data. We have some data in there, and I think for us to put in the data around not putting the outcome data first, like putting the data around how are people harmed by systems, or how are they at grade, what are the barriers first, and then putting the data around their different health outcomes. And because there is that piece that is easy to put to reinforce people's thoughts, that it's like, oh yeah, like LGBTQ people have higher rates of substance use because, and they fill in their own thing, as opposed to saying LGBTQ plus folks have are more likely to be victims of violence, have greater, all the barriers first. It really shifts the focus on and where we place blame. Sorry, Zoe.
No, not at all. You can go ahead and advance to the next one. So we just have two more, and then we're going to get to questions on discussing. So I think, resisting / managing time urgency and constraints of professional culture. And I think that we, I think there's a much more open conversation about this going on for folks who are thinking about, diversity, equity, and inclusion, but it's still a very real issue of you've got, your deadline for your project, and you've got to hit that deadline. And so I think not sort of squeezing, not getting squeezed by that, or naming, yeah, that was a factor and that influenced how we were what we were able to do. And then finally, there's two more. So utilizing cultural liaisons and brokers whenever possible. It's great to see this is happening more and more. And I think bringing that into the planning process as well, and compensating people is really key. And certainly challenges there in that, people who are working in direct service, direct support are often really squeezed for time. And so, I think building more capacity there around folks who are able to get involved with planning processes is, I think we see that as a need for sure. And And then finally, approaching community engagement with a trauma-informed and relational lens. I'm missing the word lens there, but I think we don't want to make people tell us again what their needs are. I think there's often a sense of, yep, I've done 10 surveys and said what I need. And, so having, using the sources that have already been collected, working closely with people who are running organizations that are focused on needs, and being discerning about when you bring people back to the table. And it's a balance, because you don't want to leave people out. We don't want to be making decisions about people's lives without them at the table. And at the same time, we want to be thoughtful about not kind of asking people to say the same, share the same information they've already shared. So we want to talk a little bit about how, what do you think? How will you apply these concepts? Where are you already embedding a health equity lens or thinking about it? Do you have successes and challenges you'd like to share? Are there pieces that resonated for you? We'd just love to open it up and hear from folks.
And feel free to just unmute yourselves. You're welcome to raise your hand if that's more comfortable, but you're also welcome to just unmute yourselves. Yeah, Haley.
Thank you so much and I'm so bummed because I joined the meeting a little late because I had another meeting, and I apologize. So I didn't get to catch the earlier parts, but I really am, so much of what you both said resonated. And I'm wondering if, because Liz, you said, this isn't a work plan, it's more of our, not necessarily even pie in the sky, but it's kind of where we need to be moving towards. But how do we measure some of this stuff? I think that's where I get like so bogged down in some of the details of like, if looking at those big goals that you have for your strategies, like how do you measure the impact on equity? If I'm, I'm reading so much, and I'm trying to like read and attend any webinar that I can, is like, what are some of these like measurements of equity that we can make sure that we are either asking or making sure that we're collecting that information, or so that we know we're moving the needle on this.
Do you have thoughts, Zoe? Do you want me to answer? I have some thoughts, but
You jump in.
It's a loaded question. I'm sorry.
I think it's a great question. I think it's one we should be asking ourselves all the time. And I think it's this combination of like, we need to ask that question all the time and figure it out, and we can't let it hold us back from doing. So it's like a both and. And so I think partially we were doing the big data dive for us, data to look and see like, what could we measure? What is measured now, and what can we measure, and how can we measure parts? And also, we heard from somebody very specifically that said, was like, I can't go for grants because we don't have the data on LGBTQ plus people. And so I can't even ask for the money because I don't have the data. And so we didn't want that to hold us back from putting in what it is that we need to do. And I also think that was why one of the major outcomes in the first bucket is really thinking about how do we build our capacity for data collection of disaggregated data at the local level. I think we have it at the state level, but I don't see that we have it at the county level. And so I think that's really the next step for us in the work in progress, but we didn't want it to hold us back from being aspirational in what we were saying we have to do.
Yep.
So I think we have to now break it into parts. right, into its little parts and say, how can we collect the data on these individual parts? And then what are the parts that could be collected on the whole? Because there are, it's like if 30% of people who identify as Black are living in poverty, we know that today, in Cumberland County. So 7% of white people are living in poverty. 37% of people identify as Black are living in poverty. I think there are measurements that we can look at over time. Like, are we shifting those things?
Awesome. Thank you for that.
But yeah, I'm with you. It can go overwhelming thinking about it. Like
Yeah, and I think like even as you were saying, like that data is just also not available on such a, thinking the county, and then, with us in Portland, even sometimes just on the local level, and how do you move in that direction? So I
Totally.
know this is awesome. Thank you so much.
Thanks, Haley. Thanks, Liz. We only have a few minutes left. Does anybody have anything they want to add to, maybe success or challenge or another question before we wrap up?
Sent you a couple questions, Courtney, that came in.
Yeah, I had a similar question to someone else, kind of piggybacking on Haley's a little bit. What do you think is the timeline for the work project, for the chip? And then following up on that, if you have time, what's your advice for how often you think we should be revisiting those?
And we did this one as a 4-year chip. So we thought of it as a 4-year process. I think that part of the reason we thought about it that way is, or at least the way I thought about it is, I think that because Cumberland County, the Public Health Department is new, I think we wanted to revisit because I know we're going to build new relationships and have a new understanding and new collaborations with folks, that we're going to want to revisit this, because this, I feel like, was really like at least I think other folks that were involved have been doing chips and have been doing work around this for a while, but at least for the county public health department, many of the relationships, are new. And so it's going to be important to revisit it and say, things have changed, or we have new things that we need to be doing, or we understand the problems differently. So I think 4 years is probably a good amount of time. But that might change as we go and say like, ooh, we really didn't hit the mark on that. Or, yeah, I guess I don't know the answer to that totally specifically, but I mean, we did it as a 4 years. I don't know. Zoe, do you have thoughts?
Well, I think just in terms of the question of how the work will unfold, or I think that was part of the question is,
Oh, yeah.
I mean, that is to be determined. And I think it's amazing how when you start to, I mean, I think the beauty of prioritizing these things is then as you start to tune into what the opportunities are to fund them, you see them where you wouldn't have seen the opportunities before. So looking at, I think, there'll be and this is in Liz's hands, not mine, but there'll be a process to look at, okay, where do we start? Where do we have the most momentum? Where do we have capacity? And I think using an equity lens for that as well, so that, it's saying like there were these capacity building pieces that were more like to where the conversation needed to be continued. If those don't have resources, how do we make sure we get them?
Yeah, that makes a lot of sense. I really appreciate how you spoke about not asking how health equity is so essential in order to find out what the problems really are, so we don't keep recycling all of the problems. So I can see the particularness in that, and I appreciate it. Thank you, Liz and Zoe. Our time is up for today. I really appreciate it. Can we find this information on the Portland Health Department's website, or is that yet to come? Will it be public?
Yes, we'll put the county health improvement plan on the county's website and the public health department, hopefully soon.
Okay.
We'll make sure it gets to Maine Public Health, so that it can get out to all of you. So thank you so much.
Great, thanks. And Becca put in the chat, join us for the next webinar, Transgender Public Health in Maine through the lens of tobacco use. 10 a.m. on Thursday, November 3rd. The registration link is in the chat.
Thank you.
Thanks everybody for coming.
Thank you.
Thank you all.
Thanks so much.